Device infection has a tremendous impact on healthcare systems since they pose a high cost to manage infection that can be as high as 70,000 euros per patient to manage an infection, as recently reported in the UK literature that addressed seriously this problem in a cohort who had a 3.5% infection at 1 year after implantation. In other European countries, this was proven to be quite similar. In the French registry by Clementi, infection rate raised up to 2.5% and were worthwhile an expenditure of 35,000 euros per patient. And this compares nicely with the German report that reported a 4% infection rate at the cost of 50,000 euros to manage each patient. And this is depending not only on lead extraction procedure, but hospital patient care and new implant of a device to treat the patient underlying rhythm or heart failure disease. Confusing evidence about the true incidence rate of device infection across different populations worldwide, ranging from 1.5% in the PADIT study up to cohort studies that reported up to 5%. Now we have this newly available evidence recently published on New England Journal of Medicine of the ROPIT trial results that enrolled a consistent 16,800 population of patients worldwide in 180 different centers and found a 1.2% incidence of CID infection in the control arm. The study was comparing in a randomized manner addition of an envelope who has antibacterial properties versus optimal medical prophylaxis. And it was found to be worthwhile as it reduced infection rate by 60% as a local infection in the pocket and 50% as general CID infection. What is remarkable in this study is that the effect of the envelope was consistent across all the main patient subgroups. And although it was more evident in high-power devices, the extent of infection reduction was similar also in low-power devices. The devices enrolled here were those of patients undergoing either replacement or replacement and upgrades to a superior function by addition of more than one lead, and also a small subgroup of first-time recipient CRTDs. So this applies to a broad population in our clinical practice. The applicability of this prophylaxis is a challenging one because at the first glance the study promotes its use in a very broad scenario irrespective of patient profile, but we must admit that this is based on comorbidities and disease etiology. We couldn't go deep into risk factors just because the event rate is so low. But if you look at from a broad perspective, for sure it's not really attractive that you have a number needed to treat as close to 200, which make its economic impact on healthcare system a debatable one. So possibly at each national level there will be a debate about who are the patients most likely to benefit from this prolonged prophylaxis. Because for sure there will be patients too sick to prove an evidence, or patients with a too low risk to prove an evidence, and a majority where I believe it will be self-evident that the envelope plays a definite role to prevent infection. That anyway, even though it's a rare event, it's a really catastrophic one based on patient individual outcome. The practice of extraction is one that tries to help healing a patient who has a device infection, but has definitely risks and short-term drawbacks. So we should be as effective in prevention as possible. And one way to prevent is use the antibacterial envelope in the highest risk subgroups. Now, we don't have sub-analysis to identify better high-risk subgroups in the ROPIT, but probably we will have it in the future. So far, I would say that every patient that receives an upgrade or a high-power device replacement is a high probability candidate to the envelope. And also possibly those patients who are low-power devices candidates who have comorbidities that require anticoagulation or long-term steroid therapy.